Today's symposium is on colon cancer. Of late, we find that cancer has been in the news and in the forefront of a lot of illnesses. And colon cancer is one of them that is, people are becoming more aware about it. And the people are understanding that it is one of those cancers that if you know about it early, there's a great possibility that she can reduce the likelihood of death. Now, as you can tell, I'm new. I'm a mere HR practitioner. That's all I am. But we have somebody who has all the information, and that person is our own Dr. Mills, right? And we must give a very, very big shout out to our own health center through Keisha Banbury. I was about to say Dr. Banbury. I'm wrong, but it's not him this time. It is Mrs. Banbury, right? And she has brought something different from the health center and the collaboration with HR. If you notice, we have been pushing a lot of things. They are seeing things happening. And it's because that mighty duo of my own Kaden Morris and Nurse Banbury, I think that's an absolutely dynamic team there. And so, without any further thing from me, I want to welcome you all. Thank you, Dr. Mills, for taking the time out to participate in this symposium. And we are sure that whatever information that is given today, it will maybe, if it's even saved one life, it would have been worth it. Thank you so much and welcome.
All right, good afternoon, everyone. My name is Limel Anglin from HRMD. I will be doing the prayer for the opening. Please join me as I pray. Father, in the name of the Lord Jesus Christ, we give you thanks for this opportunity that you've given us to be gathered here. We thank you for life, Lord God, which we know we cannot have without you. In you we live, move, and have our being. And Lord God, as we will be hearing and learning about what will be presented on today, bless the presenter in helping him, assisting in what he will present, Lord, and also our minds to be receptive to the things that we will learn, how we can help ourselves and others in trying to get away from this killer of cancer, this killer called cancer, Lord. And these and other mercies we ask in Jesus' name. Amen.
Good afternoon, everyone. I'm Keisha Banbury, Sister Banbury from the University Health Center. So I'm here just to give you a brief intro into this thing called cancer. All right, so cancer is no joke. What is cancer? Cancer is caused by uncontrolled overgrowth of normal cells within the body, producing a lump or tumor. This happens with all cancers except in leukemia. Cancer has the ability to spread throughout your body. Cancer is the second leading cause of death in the world. Cancers were second, causing almost 1 in 5 deaths. Taken together with heart disease, cancers are causing every second death. Some cancers have some type of genetic component to them, with some these alterations being inherited, while others occur by chance or occurs from some kind of environmental exposures, which usually occurs over years, many years. There are types of cancer, 5 types. Carcinoma usually starts on the skin or tissue lining or covering internal organs. Sarcomas starts in the bones, cartilage, muscle, fat, or blood vessels. Leukemia starts in bone marrow, causing several abnormal blood cells produced to go into the blood. Lymphoma starts with the immune system, brain and spinal cords, called the central nervous system cancers. Your risk factors. There are carcinogens, which are cancer-causing substances. Genetics, usually how we are designed, so it is inherited. Age refers to types of cancers that are more common with age. Overweight, obesity, this speaks for itself. Tobacco use, the immune system. Those who have a weakened immune system are prone to develop specific types of cancers. Ionizing radiation, infections caused by, example, the human papilloma virus, workplace hazard due to repeated exposure to cancer-causing substances due to the nature of the work. Signs of cancers. Cancer symptoms are many and different, and it depends on the location of the cancer. You have cancer without even knowing you have it. Some cancers grow very quickly, while other cancers are very slow growing and can even go undetected for up to 10 years or more. Certain types of thyroid cancers are very slow growing and may never spread beyond the thyroid gland. Making the diagnosis. If cancer is detected early, and that's why we're doing this talk, that is before it gets large or even starts spreading, one stands a better chance of a successful treatment outcome. If cancer has spread, the chance of survival is greatly reduced as treatment has become more difficult. If you think you have signs or symptoms of cancer, it is important that you speak to your doctor. The way to get started is to quit talking and begin doing. This is what our dear Walt Disney has said. So we need to reduce the risk and adopt a healthier lifestyle. Limit your intake of processed meats. Eat meals with a wide variety of fruits and vegetables. Reduce alcohol consumption. Do not smoke. Wear sunscreen to protect yourself from the sun. Practice safe sex. Get immunized against hepatitis B infection and the human papilloma virus. Get regular health checkups. And in summary, cancer can strike at any time and at any age. Early detection is the key. Know your body and family history. Do regular cancer screening when recommended. Talk to your doctor about your risk and which screening is right for you. Thank you. Let's enjoy living your life to the fullest. I have the distinct pleasure of introducing our guest speaker today. And he's not only a very good friend of mine, but like I said, our special guest speaker here to talk on colon cancer, Dr. Mike Mills. Dr. Mills is a graduate of the Doctor of Medicine Internal Medicine program here at the University of the West Indies, Mona. He's an associate lecturer in the Department of Medicine, University of the West Indies, and in private practice. He's a member of the Association of West Indian Gastroenterologists, the American Society of Gastrointestinal Endoscopy, a fellow of the American College of Physicians, a fellow of the American College of Gastroenterology, and a fellow of the Royal College of Physicians in Edinburgh. Dr. Mills is the Vice President of the Medical Association of Jamaica, Governor of the West Indies chapter of the American College of Gastroenterology, and a past President of the Association of Consultant Physicians of Jamaica. He has published in peer-reviewed journals presented at numerous seminars in various topics in gastroenterology. He has participated in numerous public awareness events and media activities covering digestive diseases, often with emphasis on colon cancer screening and liver-related diseases. So you see, he is well equipped to talk to us today on the topic of colon cancer. Let's put our hands together and welcome the esteemed Dr. Mike Mills.
Thank you very much, Keisha, for your introduction. Good afternoon, everyone. Let me just try and pull up my slides. I think so. Oh, I don't know what you're seeing. That's okay. You're supposed to see that. Don't worry, it's not broken. All right, so let us get into it. All right, so don't worry, there's no copyright that's being broken here. But the reality is that everyone recognizes what's supposed to happen at this point, yes? What is it? What are we seeing here? Two white lines, yes. Because we want to talk about colorectal cancer screening, yes? You're still not seeing? Whoa. It is broken. I'm seeing presentation, they're not seeing a presentation. So let me just yeah, I did. Resume. What's there now? So it keeps saying resume for each one. Wait, what? Oh, so hers is still up. Okay.
Close the previous one, yeah.
That's why.
Wait, close it again.
Yep. Awesome. There you go. Black and white. There you go. All right, so we're going to talk about colorectal cancer screening. And just looking out at the audience here, I'm not sure how many individuals here qualify for screening, but those who have qualified for screening know themselves. But the key thing is that not everyone who is here needs to do screening at this time. Everybody needs to know about screening, because at some point you'll either come across someone who already should have had screening and you can advise them, or eventually, as you'll see, you too will reach the point where you need to have some kind of screening test done. So it's very important to get information about some of these conditions as they apply to you personally and then those around you. So who recognizes this individual? Does anyone know who is on the screen at the moment? And if you think you know who it is, you can just raise your hand. Okay. A young Mike Mills. I'm going to say no, but we do have, yes, who is it? Mr. Chadwick Boseman. The man's name is not Mr. Wakanda. But, to be fair, yes, you're recognizing Chadwick Boseman. So these are his bio data. So he went to Howard University in the US. He graduated in 2000. So he was a young fellow when he graduated with a fine arts and bachelor's degree. He went on to his first TV role in 2003, so he's still very young at the time. Went to star in a number of feature films, some of which you may or may not have seen. And all the way up to 2016, he was a relatively unknown young men. Up until, of course, his most famous role, where he was now dubbed as Mr. Wakanda, apparently. So the Black Panther was his most famous role. And during that role, he obviously took control of the screen and was thought to be a very powerful presence, yes? No one could have suspected that he was ill. But in 2016, he was actually diagnosed at the age of 43 years with colon cancer, and he passed away in August of 2020. Quite a young man at the time when he passed away, and very surprising because obviously seeing him in his role, you would not have recognized that he would have been ill up until the very end, and so came as quite a surprise to basically the whole world, because he kept it from most individuals, and only at the very end did individuals recognize that he had colon cancer. Now, it's not just international stars that are affected by colorectal cancer. Even locally, we have some of our more well-known Jamaicans. So here, Feluke, if you remember, also diagnosed and died with colorectal cancer. John Holt also had colorectal cancer. And of course, politicians not spared in the public arena. We do know of Dr. Peter Phillips, who was diagnosed with colorectal cancer and underwent treatment. And the last of our celebrities who was diagnosed, or Songbird Karen, who unfortunately succumbed to colon cancer as well. So it's something that reaches us in Jamaica as well, and not just internationally. But as we go on, we see more and more individuals who have been affected, and of course we want to know more about the condition to see how it affects us and those that we know. So we're speaking about colon cancer. And as Keisha mentioned, cancer is something which is very prevalent worldwide. It affects a number of individuals and causes death. Colon cancer is one of those. It's the third most common cause of cancer-related death in Jamaica. So for males, prostate and lung would be 1 and 2, colon would be 3. For females, breast and cervix would be 1 and 2 in terms of cancer-related death, and colon would be number 3. So it's very common in males and females when we're talking about cancer. Jamaica Cancer Registry reports an incidence of about 13 per 100,000 cases locally. So it's an intermediate type cancer. It's not rare, it's not super common, but it is common enough for us to be concerned and to take steps to try and mitigate against its presence. Now, like cervical cancer, colon cancer in particular can be prevented with screening. Okay, so everyone knows about pap smears for cervical cancer and taking a vaccine to prevent HPV, which reduces your risk and incidence for cervical cancer. And similarly, colon cancer is unique in that if you can find a polyp, which is a precancerous stage, you can intervene to prevent the development of colon cancer. So before we start trying to develop methods of reducing this incidence, we're going to try and look at some of the risk factors why individuals may be at risk for colorectal cancer. Now, both males and females have a colon. So even to this day and age, people still are surprised when we speak about colon cancer affecting both genders. Some people think it affects only males, some people think only females, but the truth is that both males and females have a colon, and everyone has some risk for colon cancer. Now, the age is the most important factor which will determine what your risk is. The older you are, is the more likely it is that you'll develop colon cancer. So with advancing age, and usually age above 60 is where we find the highest prevalence of colorectal cancer. It doesn't mean it can't occur before that, but as you get older, it becomes more common. If your diet is not adequate, so if your diet is very high in fat, for example, that also increases the risk for colorectal cancer. There are some other dietary factors that we spoke about in the presentation before. So having a diet which is very high in processed meat or red meat also increases your risk. If it's very high in, we spoke about fat before, but if it's low in fiber, it also increases your risk. If there's a history of smoking, that also increases your risk of colon cancer and other cancers, of course. Excessive alcohol consumption also increases your risk for colorectal cancer. You also need to know your family history. What is your genetic risk profile for colon cancer? So it does tend to cluster in families, and there are different conditions which may make it more likely in terms of a genetic predisposition, but you do need to know what your risk profile is from the family. So you need to ask your siblings, ask your parents, grandparents, aunts, uncles, have you ever been diagnosed with colon cancer? Do you have any polyps? Because this increases your risk for colon cancer, and there are some steps that you need to take if your family history is significant. Ulcerative colitis is a medical condition which can also increase the risk for colorectal cancer. It's not very common, but those individuals who are affected by it also have an increased risk of colon cancer. So these risk factors would be quite important to identify, because you want to decide, are you at high risk or average risk for colon cancer? Now, most individuals would be at average risk based on the risk profile. Having identified these risks is not enough for you to be able to decide if you actually have the condition. And one of the common things is people want to know, well, what are the signs of colon cancer? How do I know if I actually have colon cancer? Because, of course, you don't want to be having the condition, wondering about it, and not taking steps. So you want to also identify what are the typical things which you may experience which would indicate that you could potentially have colon cancer. Now, usually, signs and symptoms will present when the cancer is quite advanced. So Nurse Banbury spoke before about waiting sometimes up to 10 years for certain cancers, depending on where they are, before you actually notice anything. For colon cancer, it's not as long as 10 years before symptoms start to show up, but in the early stages, the cancer may not be providing any symptoms or any indication that it's present at all. So waiting for signs and symptoms before thinking about it, you may already be too late to intervene in the way that you want to. But if there are signs and symptoms, they're usually confined to the area that the bowel is. So you need to know where the bowel is to understand how the signs and symptoms arise. And just to be sure that we're all on the same page, so when we speak about the colon, we're speaking about the large bowel. So this diagram here is showing you the intestine. And so the large bowel ends in the anus and rectum, and going backwards, there's a curved part called the sigmoid colon. Then there's a transverse part that goes across the body, and then there's a part that goes right back down to the start of the colon, which is the cecum, which is right where the appendix joins. So where your appendix is where your colon starts, basically. And then things tend to go up, around, and back down, get stored in the rectum, and then exited. So this is your large bowel or colon. Now in there is also small bowel and stomach and other organs in the abdomen. So whenever anything is happening inside there, it doesn't necessarily mean that it's coming from your colon, but it's one of the symptoms and signs that will clue you in that something is happening. So to look at the function of the colon will determine what the signs and symptoms are. So the common thing is a change in your bowel habit. So if you're used to having a certain frequency of passing stool, if that changes and it's not easily explained, then of course that's a concern. Now there's a normal average that we expect people to pass stool. So if you're passing stool on average every 1 or 2 days, 1 or 2 bowel actions per day, which is without effort, without blood, without pain, that's normal. Once it changes, however, then this is something that you need to pay attention to and decide if there's something which either you're doing. So the commonest thing, if it changes, is because there's a change in your environment. You're eating differently, you're taking some medication, you're dehydrated, you're otherwise ill. Something has changed which results in a change in your bowel habit. If you recognize it, you can always make that adjustment. If it's persistent, however, or there's no explanation, or it's accompanied by any other signs or symptoms, then you need to get an explanation as to why the bowel habit has changed. And the older you are, the more likely it is that we'll be concerned about cancer being the cause of that. So then knowing a change in your bowel habits, or recognizing what your normal pattern is, will then give you an idea as to when that changes. If there's blood in the stool, that's also another sign that there's something happening inside the colon. Now, it doesn't mean that it's cancer. Most times when there's blood in the stool, especially if it's bright red blood, then it's usually associated with something like hemorrhoids or piles, and that's something which can be associated with constipation. But, of course, you don't want to ignore it, because it may not be piles. Even if you know you have piles, it could be something higher up in the colon, so you need to check it out, get a diagnosis, confirm, especially if you're older, confirm that it's not just hemorrhoids or something else. Those are the typical features. There are some other things, depending on where the cancer is, which may indicate as well that it may be present, but we will look at those symptoms at another time. So, looking at the statistics, essentially, 9% of the cancers that the Jamaica Cancer Registry looked at between 2003 and 2007 revealed that colorectal cancer was present. For females, it's approximately the same, 9.4% of cases. Now, it doesn't mean that all cancers are represented here. This is looking at Solid tumors, those cancers which are excluding leukemias and lymphomas, which also play a role in our national epidemiology. But across the board for solid tumors, approximately 9% of the cases are due to colorectal cancer in both males and females. So for screening, just to go back over to make sure that everyone is clear, for females, the screening tests that we recommend would be your mammogram, pap smear, and a colon check. And for males, prostate check and a colon check. So these are your screening recommendations for colorectal cancer, breast cancer, prostate cancer, and cervical cancer. Now, it's not just constipation which may be associated with colorectal cancer. Other features may also suggest to you that there is an indication that you need to pay attention to your diet. Diarrhea is also a potential presenting feature of colorectal cancer, and that's why we say a change in your bowel habit is something you need to pay attention to. Mucus in the stool is a normal feature of stool, so the colon is going to produce mucus. A lot of times patients come and say, well, I see a lot of mucus in my stool, is it because I have a cancer? Most times the mucus is actually because they've changed something in their diet, and the most common thing is usually an increased intake of some type of vegetable material. So most times when we see mucus in the stool, it's not from cancer. But still, there's a change, as we said, and the change is what we're interested in, identifying what's causing the change. So if it requires you to visit the doctor to see why there's a change, then certainly you need to go ahead and do that, and then get a diagnosis from there. Now, the other signs and symptoms which may suggest that the cancer is present relate to the size or stage of the cancer and whether it's affecting any other area. Loss of appetite, unintentional weight loss, these are things which may indicate a cancer. There are other things, of course, which can do this, but you need to pay attention to that. The blood count or hemoglobin, so when you do your annual executive profile, for example, even without any signs or symptoms, they're going to check your hemoglobin, which is your blood count, and if it's low, it may be an indicator that you've been losing blood somewhere. And one of the typical places that you tend to lose blood if it's a cancer is inside the bowel. And so looking to see if there is iron deficiency anemia may be an indicator that there's something happening in the colon, even if there are no other signs or symptoms suggesting that. If you're over the age of 50, as we said, increasing age, increasing frequency. So as you get older, we become more concerned about the reason why you may be experiencing some of these things, and we need to do some type of test to determine whether or not colon cancer is present. Now, there are a number of tests which look at the bowel. You may have heard about some of them. Some of them are useful for screening. Some of them are not as useful for screening. Barium enema, for example. So most people would be familiar with the barium enema. It's one of our older tests. It's an X-ray type of test. And you can see from this image here, so to do the barium test, individuals have to empty the bowel, so you take laxatives beforehand, and then you go to the X-ray facility. They will put contrast, in this case barium, which is a white thing inside your colon. They'll pump it inside of you and ask you to turn on a table so they can outline the bowel and then take some pictures. So this is showing the colon with barium inside with air. So anything that's sitting on the surface will then be outlined by the barium when they take the pictures, and they'll determine if there's something growing in the colon. So it's one of the early tests, readily accessible, to give an indication as to whether there is something wrong. So this barium picture, for example, shows you a little thing here, like a small pea. So this little outline is all that's indicating that there is a polyp. So this is not cancer, it's just a polyp. Now, it's a polyp only because I say it's a polyp. Now, it could be anything. The point is that it's just a black and white picture of liquid running over something which shouldn't be there. So it could be stool. So if you had rice and peas on Sunday and then you do the test on Tuesday, a pea could still be in your colon because you didn't empty it out properly, and when they put the barium in there, it's just going to outline around the little pea, and all they see is that, oh, something is blocking up the barium at that spot. Could be a polyp, or it could be the pea. It's just that when they move you around on the table, the barium is supposed to move away the little pea, and so it could move in different positions, but it doesn't have to if it's adherent, or if it's stool that's sitting there. So the barium enema gives you a rough idea if there's something wrong, but it doesn't give you any details. Okay, so it's one test that can be done. So what does cancer look like on a barium? So on a barium, here you see another picture of a barium. There's lots of barium, which is white. And anything that's on the X-ray that looks black is air. And then anything in between is like soft tissue, and the white over here is bone. So inside this person's colon, there's lots of barium, which is making the passageway very obvious because it's collecting in there. And then up here, you see some barium and you see some air, so the bowl looks normal. But then right here, there's this thin white area. So there's still barium here, so the barium is white. Oh, you not see my arrow? All this time I'm here pointing away like mad, and I'm like, yes, and you're like not seeing anything. 3 slides later, I describe it for you. Okay, fine. So, yes, IT, sir. Thank you. Awesome. Are you seeing this little red thing? Okay. Awesome. Okay, so right here is this normal barium, which is white. And then up here is normal bowel with air. So this white thing is a barium. Up here is barium and air inside the colon. And then here now, there's a thin little thing which is connecting the 2 pieces. So this thin thing is the barium, which they put inside your colon. And then because it's trickling through a narrow space, that's why you're only seeing a little bit just dripping through until it kind of fills this place again. So this narrow space is because something is basically making that part of the bowel, instead of looking like a nice tube, it kind of gets crushed and squashed and leave a little passageway for liquid. And that's because that's where the cancer is. So the cancer is making that area very narrow, so it's very hard for stool and stuff to pass through. So you present with constipation because stool can't go through there easily. And this is a later stage. Okay, so we call that an apple core sign, because it looks like, if somebody has eaten an apple, well, not a local apple, like an American apple, where you just eat around it and then you leave the core of the apple. So that's what that looks like, right? So this is the middle of it. So that's a barium. It gives you a fair idea that there's something there, but it's not the only test we have available. There are better tests to look inside the bowel. So more advanced tests would be a CT or CAT scan, colonography, which is looking at the colon in the same way. So this is basically looking inside the colon. So you've done the same type of prep where you empty the bowel, and then they ask you to drink some contrast, and they put you back in a CT scan machine. If you've ever done a CT, you know what that's like. And then they take pictures of the colon, run it through a computer, and the computer will then generate these pictures of the colon. So this is looking inside the colon now. So you're not looking from outside, you're looking inside. It's like you're sitting inside the colon, looking down this passageway where stool is supposed to be. And all these folds are the muscle layers inside the colon which help it to contract and move stool through it. And there are 2 things on this image which are not normal. So this is one thing which is not normal, and then this is another thing which is not normal. Okay? So who knows what this thing is? Polyps. My work is done. Goodbye. Okay, yes, that's true. This is probably a polyp. Now, probably because, again, the computer is just showing us what it thinks is there, but until we're actually in there for sure, it could only be a few other things. It could be some foreign material, as I said before, if the colon is not properly prepped. But yes, this could be a polyp because it's sitting on the surface of the colon. Now, this other thing, who knows what this other thing is? What is it? I'm getting all silent now. It's like, oh, I don't want to lose my 100%. Okay, so this thing is not a mass. It's the opposite of a mass. It's a hole. All right, so it's diverticular disease. You're correct? What kind of work do you do? Well, customer service. All right, so in customer service, when someone comes to you and they ask you a question like, how do I find the HR manager's office, right? Do you answer them and say, well, you go upstairs, turn to the right, go through the first door, and then knock on wait? Yes? Or do you sit there and then you say, oh, there's probably upstairs. None? What you do? You just say, well, I'm not here. Yes. Yes, so you engage with them and then you present yourself well. And so that's the thing. So if you don't answer the question so that we can hear it, we can't give you the mark. So it doesn't make sense to stay down there with the answer and just kind of, it's diverticular disease. No, you have to be convicted, your conviction, because so you get the full marks and you get your credit and stuff. So yes, it's diverticulosis. It's a small pocket in the colon and it's an indentation, whereas a polyp is a projection into the colon. Diverticulosis is the opposite. It's like outside, like a little bulge or a sac or a bleb on a tire, which is what patients can have. So it's not associated with cancer, but it's very common as you get older as well. So this is a CT, which is one of the screening tools which are available locally as well in place of another test that we'll talk about later. So we speak about screening for the colon. So we need to figure out when to do screening and what to do. So everybody over the age of 45 should have some kind of screening test for the colon, look for cancer, right? So screening now is no signs, no symptoms, you want to do a test. Okay, if you're doing signs and symptoms, that means you're doing a diagnosis. That's different. So even if you don't feel anything, you want to do a test, that's called screening, to look for the early stage of it or preventative stage, like the polyp. So 45 is where we're targeting. And if you're over 45 and you missed 45 and you haven't done it, it's not too late. There's a certain cutoff that we do, so after age 75, we tend not to do any screening because it's not really worth it. But if you're well at 75 and you're projected to live to 100, then we may continue if you're well enough to undergo screening. So it's a discussion that you have with your doctor. So if a relative of yours had cancer, so remember we spoke about knowing your family history. If your relative had cancer, then you want to know what age they had colon cancer, because if, for example, they had colon cancer when they were very young, then you want to do your screening 10 years before their diagnosis if it's younger than age 45. So if they were diagnosed at 50, then you're not going to wait until you're 45 to do screening, you're going to do it when you're 40. So that's why you need to know what the family history is so you can figure out when to start your screening. Now there are outpatient tests, lots of tests available. It doesn't mean that you have to be admitted or anything dramatic, but some kind of test needs to be done. Now, because the incidence is increasing locally, it's important that we take steps to actually increase our ability to figure out which test to do, when to do it, how to access it, so that we can try and prevent colon cancer. So as we said before, colon cancer, like cervical cancer, is imminently preventable if we take steps to do some kind of screening. So here are your screening tests available. Annual fecal occult blood. Okay, so fecal occult blood test is a stool test looking for blood. So we said before, if you had a cancer, it could bleed. So if you can find blood in the stool, this is not when you see it, but this is when the lab sees it, then that's a screening test just by itself. But it's only the first step. So if you find the blood, you have to do something to figure out what's causing it. So it's a two-stage screening step. But if you do the stool test every year, then you're well ahead of the game, okay? The next test is a colonoscopy. And the colonoscopy, which we're going to talk about, is done every 10 years if you don't see anything. Then we spoke about barium enemas. Barium enema is not recommended as a screening tool because it's not effective enough to pick up enough of the early stages of cancer to be able to do anything. So we don't recommend it as a screening tool. We tend to miss things too much if we rely on a barium. And then the CT, which we spoke about before, is also a screening tool. So the options available locally are the ones that are on the slide. A stool test, looking for blood, and there are different ways to do that. Colonoscopy, and a CT. Now, this person tried to increase awareness of colorectal cancer. And everybody knows who this is, right? Yes. So, who? Oh, I thought it was a man who was slapping people at the Oscars. All right, fine. So, yes, Fresh Prince of Bel-Air, that's true. So he filmed his colonoscopy screening to try and increase awareness, right? And just by doing that, if you go on YouTube, you'll see his experience and that increased awareness based on the number of views. So the colonoscopy is a test which I'm sure a lot of people have heard about. This is what we see when we pass the camera inside the colon. So this is what the colon looks like. inside, when we empty everything, so we ask you to take laxatives, empty out the colon so that we can pass the camera in, and we distend it with air so it's not normally so distended. We put air inside to blow it up like a balloon, and then we look around on the wall to see if anything is wrong with it. So that's a normal colon, okay? So that's what we hope to see. Now, if it's abnormal, then you'll see this thing, and everybody sees the thing on this slide, right? So on this slide, let me see the pointer, this thing. So this thing is a polyp. So the polyp is this little warty growth that sits on the colon, which is the precursor to cancer in most cases of cancer. Now, not all polyps turn into cancer. Most actually don't. But most cancers will come from a polyp. So if we can find a polyp, then we can take it out and prevent the cancer. So that's the whole goal here. Now, you're not going to have any symptoms if you have a tiny polyp like this. So if you do a colonoscopy early, find the polyp without any symptoms, we take it out, then that should prevent you from getting cancer. So that's the goal. Now, this is just me biopsying this polyp. So this is another colonoscopy. Now, if you don't take out that polyp, it's going to grow. So if it's going to grow, then it's going to get bigger like this one. So here it's bigger, right? So it can get bigger, and the bigger it gets is the more likely it is to produce symptoms, okay? So these can bleed, and then it will show up as obvious blood in the stool. So the bigger it is the more likely it is you have symptoms. It's still not cancer, though. So you can still get a chance. Take it out at colonoscopy before it gets to cancer. But if you don't do anything, then it's going to even bigger, and it can block up the whole passageway. And if it's blocking up the passageway, at this point now you're going to have some change in your stool. So that's now it's having some symptoms. Still not cancer, though. We can still take it out. But it's obvious that something is not right. And if you don't take it out, then unfortunately, you can get this thing. And this is not what you want. So you don't want to see the cancer. Okay, so this is cancer inside the colon. So it's obviously taking up space where it shouldn't be. It doesn't look anything like the normal colon. This whole thing here shouldn't be here. So the only passageway for stool is just underneath here, this little narrow space. And it's basically taking up the whole wall. All right, so this is going to bleed. This is going to now start to spread and cause all the problems that are associated with colon cancer. So we're trying to prevent that by doing the test to take out the polyps before it turns into this. Okay, so that's the objective. So yeah, if we biopsy it, we have to sample it to send to the lab to test it and so on. So that's what's causing the bleeding at the moment. All right, so it doesn't just turn into cancer overnight, as we said. There's a stage progression that it has to go through. So it takes, on average, 7 to 10 years for a polyp, which is like a tiny warty growth inside the colon, represented here, to go all the way into a cancer. So it's going to grow over time. So you have time to intervene. The earlier you are in intervening, is the better your chance at preventing it from becoming advanced. Okay, so the key thing is to prevent the cancer and to do the screening at appropriate age. So age 45 to 50, definitely want to do some kind of a screening test without symptoms, just like how you screen with your mammogram and pap smear and a prostate test. You want to pay attention to the modifiable risk factors. So there are certain things you can change, like your diet, so cutting back on red meat, processed meat, the alcohol, you want to cut that back. Smoking, you want to discontinue completely. You want to know what your family history is, and then you want to choose one of the screening tests at the appropriate stage. Any of the screening tests, it doesn't matter which one. The colonoscopy is the so-called gold standard, so it's the one that allows you to do everything at one sitting, including remove polyps and identify them, as you said, better than some. But even if you do one of the other tests, it still puts you at an advantage. So it's important to do this because the earlier you pick up the cancer is the better your chance at survival and outcome. So this data is just showing you that depending on the stage that you pick up a cancer locally, so this is local colon cancer data, survival data. So we're looking now at what's localized. Localized means early stage, so the cancer is still inside the colon only. It's not outside in your lymph nodes or in your liver or anywhere else. It's just in the colon, and when you do testing at that stage, you do your scans, you don't see it anywhere else. You have your surgery, they take out the colon that has a cancer in it, And then your survival at 5 years, so 90% of individuals at 5 years with stage 1 cancer would still be alive. And we talk about 5-year survival because it's cancer, so we tend not to report it as forever. We just look at it in blocks of 5 years to see what your survival is. Now, the further it has spread, the longer you wait, is the less your survival chances are. So look at distant. So distant means it's stage 4. So it's spread outside the colon into other organs. It's in your liver, or it's in your lung, or it's in your bone, or it's in your brain, or anywhere else outside the colon. Your survival at 5 years, only 14% of individuals will be alive at that point. So your survival drops significantly if you present with disease that has spread compared to if you're presenting when it's just localized. And the only way you'll know if it's localized is if you pick it up very early. And as you see, you need to do it before you have any signs or symptoms to be able to determine that, and that's why screening is very important. So there's evidence that screening does work. So this graph, if it's projecting well enough, will show you some different lines representing different countries who have different incidences of colorectal cancer. So all the lines, so there's a kind of a purplish bluish line here, there's a greenish line here, there's a kind of a yellowish line here, and then a reddish line here, and a grayish line. So all the lines, for the most part, are either going straight across or they're going upwards, and only this red one is consistently at a peak and then going down for a while. So everything else is either going up and then not sure where this is going, but this one is kind of flat, this one is kind of flat, this one is going way up. So the red one is showing you incidence. So how common is this cancer over time? So this is 1970, this is 2010, and the red one is the US. So what the US line is showing compared to like Canada, Australia, Japan, and so on, is showing that at a certain point in time, the incidence of colon cancer peaked in the US and has been falling. So it's becoming less common. It's still very common, but the incidence is falling over time. And this peak and then fall corresponded with the uptake in increased colon screening. So the more they were doing screening, and particularly colonoscopy, but the more screening they were doing is the better their chances of picking up early, picking up polyps, removing polyps, and preventing colon cancer. So there's definite evidence that doing some kind of screening intervention will improve the incidence on a national level, and then on a personal level, doing some kind of screening will also indicate to you early stage, preferably before cancer forms, which is a polyp, so you can remove it, prevent colon cancer, or even if you do find it, it will be early, and then you can have surgery or limited kind of exposure to chemotherapy and have a better outcome or survival just based on doing some kind of screening test. So I think that's kind of what we want to get across this afternoon. But definitely you want to focus on prevention, and there are different things you can do to prevent. Screening is one option, definitely something you need to be aware of. You need to see what your risk is like, select a screening option, and then make some adjustments to lifestyle as best as possible where that needs to be done to try and improve the outcomes, not just for yourself, but then obviously the community, and try and reduce the burden associated with colorectal cancer. So thank you. Any questions? Yes.
Thank you so much for your presentation. I know you mentioned doing the annual stool test for blood, and I know when I do that executive profile,
You leave it out.
carry that
Yes.
stool. Nobody likes to do that. But and the important piece, because you said if you do it every year, that's great. Recently there is some what they call it,
Second generation fit testing.
are those useful? Would you recommend like that useful as well?
Yes, so broadly speaking, the ability to detect blood in your stool is best done by a test which is specific for blood. And I say that because there are different types of tests which will show blood in the stool. The traditional one, when you send your executive profile, is the guaic-based test, which is the typical occult blood test, where there's a peroxidase reaction which shows them something which the catalase enzyme will act on. Now, there are different things, not just hemoglobin, which is a pure a thing that you're looking for in the stool. Myoglobin, for example, will also activate the test, and myoglobin is coming from muscle. And there's some other muscle related things like animal products. If you eat certain foods and then do the test, it's going to interfere with the accuracy of the test. If you're taking vitamin C and you don't stop it, it's going to interfere with the accuracy of the test. So unfortunately, the first generation, let's call it first generation stool testing, which is a FOBT, which is a traditional one, it's still a very good test. First of all, you have to do it every year for it to be effective, but every year with 3 samples. So it's not enough for one sample. If you're doing just one sample, it's not doing what it's supposed to do. So the data is clear that the yield, because the yield is so low, because all you're looking for is a trace of blood in the stool, right? So the more stool you send is the more likely it is that you'll be able to pick up blood. That's the reality. So no one wants to send stool every day for a year, because that's just, the lab don't want to see that and you don't want to see that. So, exactly. So, 3 samples is enough for them to pick up a representative sample of stool to detect if there's blood there. Now, it doesn't have to be 3 samples separated by any long period of time, but definitely not 3 samples in one day. So if it's 1 sample today, another one next week, another one next month, it doesn't matter. But 3 samples for the year is what you want to have an accurate test or reliable test. Now, that's an old-timey traditional one, which has some restrictions in terms of what you have to do. Now, the second generation one is a FIT test, or fecal immunochemical test. So it's looking specifically at hemoglobin. So there's no myoglobin that's going to interfere with the testing, and there's nothing, no catalase reaction or anything which is going to be affected. So chance of you getting a false test or picking up things that are not there is just not there. So it's a more specific test for blood. And so for that reason, it's a second generation test, and it's available locally. It's more expensive, that's true, but because you don't have to send as many stool samples and you don't have to adjust your diet beforehand, it's a very useful test for doing screening. Now, if it's the only screening test you're doing, so any stool test that you do, there are different approaches to screening. There's a screening test which allows you to pick up precancerous things, and there's a screening test which only picks up cancer. So think about when you do your screening test, what are you trying to pick up? So when you do a screening test trying to pick up blood, which is what the stool tests are doing, remember something has to be bleeding for it to be picked up. And the only thing that's going to bleed, so the little tiny polyp I show you, it could bleed, yes, but it's only when it gets to a certain size that you're likely to get enough blood for it to be showing up like that. So again, something could be in there and the stool test doesn't show it, right? So doing continued fecal testing will show you something earlier than doing nothing. And so your outcome is going to be definitely better than doing nothing. And the data is clear that your outcomes, if you were to be diagnosed by doing stool testing, your outcome is better, but you're still going to be picking up something that's fairly advanced. That's the reality. So if you're doing another type of screening test, what we call the direct visualization, so you're looking now into the colon directly, your CT or your colonoscopy, you're looking now, you're just seeing what's there, and you're taking out what's in there. Doesn't matter if it's bleeding or not, you don't want it in there, you're taking it out. So that's why those tests are better at detecting the early stages of cancer, plus giving you the ability to actually intervene and do something at that point, okay? So as I said, it's choosing a screening test, there are different options, all have significant factors associated, plus or minus, whether it's cost or accessibility or having to change convenience, all these different things. But knowing what's available will definitely help you. So yes, the second generation test, definitely useful. Doesn't mean the first generation test wasn't doing anything. It's still doing it. Both of them are just looking at blood. That's the reality. It's not a magical test in any way. It's just looking at blood in a more specific way. Any other questions? Okay, scared everyone to go and do their colonoscopy now. You have options. So, as I said, it's important to be aware and then where you can make changes. If changes need to be made, you can make those changes. If it's just reinforcement, fine. If it's something that to advise someone, no problem, that type of thing. So again, thank you very much.
Good afternoon, everyone. Okay, so our second presenter is from Indus. Indus is a multi-divisional and multi-product based company with its core business activities include pharmaceuticals, customer and allied products. Indus' philosophy is benched on their commitment to make innovative and quality products available to all. With entire range, of Indus brands are manufactured based on, okay, there's an error here. But, all right. So Indus brands are manufactured in the best of the manufacturing facilities with due accreditations by global leading regulatory bodies. Brand building is a core strength of Indus, right from the product selection to customer segmentation and product positioning. The promotional strategy is based on local dynamics. Indus has received several accreditations, including FIEO Export Excellence Award, Pharma Excel Best Exporter Award, 1-Star Export House, Financial Discipline Award, and Product of the Year Award for 2 consecutive years. I will now welcome the representative from Mr. Williams. I apologize, sir.
Hello, good afternoon. Can you hear me? All right. Good afternoon. My name is Patrick Williams, and I'm from Indus Life Sciences. I'm here with my colleague Shamari Hutchinson that you see at the back here. All right. And I would like to share with you guys today our brands that we have, right? But first, I heard an introduction for Indus, right? I'd just like to add something to it. So the word Indus, it means I and us, right? So it means us, the pharmaceutical company, and you guys as well. So both of us work together to create, yes, Indus, right? All right. So whenever a patient comes into the pharmacy or to the doctor, right, they present multiple symptoms, right? Whether it be they have heartburn or hyperacidity, gastritis, flatulence, acid reflux, or an ulcer, right? You have anybody that has heartburn or acid reflux? All right. All right, no, so when we go to the pharmacist, the hardest choice is that we have a lot of antacids on the shelves, right? I won't be calling any names, but we have a lot of them. But the problem is we don't know which one to choose. We don't know which one will be most effective for us, right? And I'm here to let you guys know just a little brief history into antacids, right? So we have our first generation antacids where they have acid neutralizing agents such as magnesium hydroxide, aluminum hydroxide, and magnesium trisilicate, which helps with the hyperacidity that our patients experience. And then you have the introduction of the second generation where we have dimethicone or simethicone, which is an anti-flatulence drug, added to the first generation so that we can help with hyperacidity and the flatulence as well. However, we just solved flatulence, hyperacidity. However, we still have a problem that is left unattended, and as you guys said, a lot of Jamaicans suffer from acid reflux, heartburn. Right? Now, for the first time, we have created a formulation of antacid, right, where we have added something called alginic acid to it to make it a quote-unquote a third generation, which will be a step up from the first and the second generation as well. Now, for the mechanism of action for our new gel, the alginic acid, right? Here. All right, so as you guys can see the stomach. Everybody see the stomach, right? And we have the alginate raft on top of the stomach. So upon ingestion with the alginic acid, it is converted to what we call an alginate raft whenever it forms and mixes with the gastric juices. All right, so there we can see a little white raft, and you guys see an arrow, a curved arrow. So pretty much when you guys have something to eat, right, no matter which position you're in, what happens after a time is that if you guys have acid reflux, when the stomach contents come back up to your chest, well, not your chest, your esophagus, what happens is that if the contents are too acidic, what happens is that it starts to burn the esophageal lining. And that causes a lot of discomfort for patients. Some patients, they feel like they want to throw up. Some patients just feel like it's a burn here in the chest area as well, right? That's what we refer to as acid reflux and heartburn. Now, the alginate raft, its purpose is to stay on top of the stomach contents while we have our neutralizing agents neutralizing the stomach contents. It's to prevent any of that stomach contents from coming up the esophageal wall and to cause that burning from the acidic nature, because our esophageal lining, it wasn't made to withstand very acidic contents. However, your stomach was made to withstand all those acidic contents. Now, I'll have a little video outlining how the alginate raft is formed and how it helps. You guys can see the video? All right. So we have the alginic acid mixing and it's creating that raft. So now we have the stomach contents going up, but as you can see, the raft is pretty much preventing anything from going up. So you won't have that heartburn. All right. And then as you have seen, it's excreted completely unchanged along with the stomach contents. So we have a few questions that our patients ask, right? Now, if I take some new gel, right, and I have something to eat, will it affect anything? If I take medication, will it affect any medication or anything that I'm already taking? Can I take it before or after? Now, the alginate raft, it comes from green algae, natural green algae. And as you know, algae is made out of cellulose, and humans don't break down cellulose. It remains unchanged in our body, and it's excreted unchanged along with the stomach contents as well. So it poses no harm, right? It won't interact with any other agents, any other drugs that you will have been prescribed by a doctor. It's totally safe, right? And I would just like to show you guys the complete composition of the new gel, right? So each 15 ml contains the alginic acid, 200 mgs, magnesium hydroxide, dry aluminum hydroxide, magnesium trisilicate, and dimethicone. Now, if you look at the composition of our neutralizing agents, you'll see that we keep it in a uniform composition. Because if you have them in ununiform composition, then what's going to happen is that you might have side effects, such as diarrhea or constipation as a result of that. So for that reason, we have kept it at a constant formulation and amount as well. Right? Now, the other thing to note is that for our pregnant women, in your first and second trimester, they have a lot of stomach issues, right? Upset stomach and stuff like that. However, luckily enough, our new gel is also safe in pregnancy. Right? So the new gel, it's safe in pregnancy. It's also sugar-free as well. So it can be taken by diabetics as well. Right? So sugar-free and safe in pregnancy as well. Now, we have some patients, they come into the pharmacy or even to the doctor, and they say, boy, doc, I have really bad pain in my stomach. Pharmacists have really, really bad pain in the stomach. right? And then when the doctor checks it out, they have an ulcer, whether they have a gastric ulcer or a duodenal ulcer. What we have done is that we want to help our persons with the pain that they're having, right? That's one of our core values, to help our persons with the symptoms that they're experiencing. So what we have done is that we have the regular Nugel, we have added an extra compound to it called oxytocin. Now our oxytocin, it's a mucosal anesthetic, and it's there to line the esophageal, it's there to line the stomach lining to help the person with the pain that they're experiencing. Right? Now, for your ulcer patients, right, the doctor would prescribe a H2RA or a PPI along with something else, right? Now, for the Nugel O, it can be used along with your PPI or H2RA to allow for that instantaneous relief from the pain that the person is experiencing. Now, the only contraindication of our Nugel O is that we do not recommend it in our pregnant mothers. Because of the oxytocin, we would want it interrupting any contractions she might have close to birth. So for that reason, we don't recommend it in pregnant mothers. We also don't recommend it in children either. So the Nugel, it can also be used in children. Now for the Nugel and the Nugel O, we have it in 3 sizes. We have it in a 200 ml bottle that you can get at the pharmacy. Right, the Nugel, it is OTC, so you can go in the pharmacy, you can pick it off the shelf. We have our Nugel O now, which is a list 2 drug. So you can go in the pharmacy and you can ask the pharmacist for it. So she can give you the drug based off recommendation that, you might really have an ulcer or you really might experiencing some ulcer pain as well. And we have it in a 100 ml bottle, and we also have it in a sachet. Did everybody get a sachet? All right, so you guys can, after you guys can make your way over to the back, and we have some samples of the sachets as well. So for the sachets there, it's a 1 dosage. Yes. Oh yeah, we have both in Nugel and Nugel O. All right. So the dosage is 10 to 15 mLs. And what we have done is that, some patients, they probably might leave the bottle at home. So we have the sachets now where it's a 1 dosage container. You just pull and you just take it. You don't have to dissolve it. You don't have to dilute it or anything like that. You just take it as is. All right, now we have our second product. It's called Capsitop. So it is our pain gel, and we have 3 active ingredients in it. We have capsaicin. Capsaicin is an extract that comes from pepper. Right, so I know that when you guys use it, you might feel a little burning sensation. But just to let you guys know that when you're applying, if you're feeling the pain in one area, you can just apply to that area. You don't have to massage it. You don't have to rub it in. You don't have to spread it towards your entire body for your entire body to start burning. No, and I know we have a culture of, whenever we're feeling the burn, we know it's working, right? Yeah, right? When you feel it, but you really don't have to feel it. You don't have to feel it. In fact, if you don't feel anything at all, that means it's working. Not feeling the pain, not feeling the burn, that's great, right? We have diclofenac sodium in it, we have menthol in it, and we have salicylate in it as well. And you can get it in the pharmacy for about $700. It's available. And we have our final product, Amino Pep. Right, now, I see everybody with an Amino Pep, so I'm assuming that everybody got one. Right? Now, our Amino Pep is what we consider our big juice. Right? Now, our Amino Pep, it's a comprehensive formulation of amino acids, minerals, and vitamins. So it has your vitamins, your vitamin A, B, C, all the way down to K. Right? It has your minerals, it has your calcium, magnesium. It has your zinc in it, which is good for immunity. Right? Now I know that, we have cold and flu and all sort of things going around. Right? Just to ensure that yourself is protected, you have the maximum immunity for your body. We recommend it as it has the maximum recommended dosage of zinc in it. Right? Now we have our amino acids. Now, whenever we go to the pharmacy and we think to get a supplement, we think about our minerals and our vitamins. However, we don't think about our amino acids. When our amino acids are the building blocks of our protein. Right? The amino acids are responsible for growth, responsible for repair of your muscles, your tissues, pretty much you need the amino acids to maintain your body and to live. So it's not only your vitamins and minerals that are essential, but your amino acids are just as essential as everything else. Now, with that being said, we cannot get our amino acids from ourselves. We don't make amino acids, we have to get it from an external source, or food. Now, it's kind of hard to balance out a complete balanced diet on your plate with everything, right? You know, if it's not food being expensive, it's the time to prepare all of it. Trust me, it's a lot, right? Right, especially, right? So what we have done is that we have taken these 10 essential amino acids and we have all placed them in one bottle along with your minerals and your vitamins as well. And just to name a few, we have tryptophan. Tryptophan is an amino acid that helps with stress by releasing dopamine and serotonin. So, you know, for everybody, I know that you guys work a very, very long day. Then you have to go home to do more work, right? You guys can get flustered, you can get a bit stressed at times, right? No, I don't want to say that you're going to take 10 mLs of amino pep and not feel stress. No, that's not what I'm saying, right? However, over time taking it, you realize that you're more at ease while doing your daily activities. We also have an next one in it called phenylalanine. And phenylalanine is good for cognitive ability and memory. Right? So we have our children, even us, we have our university students going to school, studying and stuff like that. It will give them a boost in their cognitive ability just to help them study, to ensure that when it's exam time, they can sit all the exams and they can ace them. And not only the college students, but also our children in high school taking CAPE, or sixth graders taking PEP. So pretty much, if you guys realize the amino PEP, it's pretty much for everybody, right? So our toddlers can take it, right, up until 2 years and less. Breast milk is best for the child, but 2 years and over, then yeah, they can have the amino PEP. Also, the thing to note about the amino pep is that it can be used in our elderly, right? So whenever elderly undergoing sarcopenia, which is weakening of the bones and tissues and stuff like that, they start to move a bit slow. It's also good for them because the RG in it will help with their muscles and loosening as well. All right, so I hope that you guys got a full overview of all our products, and I hope everybody collects samples, and thank you. Yeah. So so she's breastfeeding beyond 2 years? Oh. Oh, is it good for her to take the amino pep? Okay, no. To note, whenever a mother is breastfeeding, she needs about 39% increase in amino acids to ensure that that baby is getting enough quality breast milk. And for that reason, we encourage our mothers to actually take amino pep while breastfeeding because they will increase the quality of the breast milk. All right? One more question? All right, now we have some patients, right? It's a commonly asked question. It's a commonly asked question, right? We have patients that, they say that it improves their appetite. Yes, it improves their appetite. However, what we have seen is that we have some patients where they have an appetite, they're fine, it doesn't affect their appetite. We have some patients that don't have an appetite at all, they say it increases appetite all the way, right? So from what I know, it affects persons differently based off their body, metabolism, and everything like that. Any other questions? All right, thank you guys for your time, and I hope everybody has a great day.
Good afternoon again, everyone. Unfortunately, our third presenter was unable to come to speak to us about the FIT test, which is the fecal immunochemical test, but our esteemed doctor, Dr. Mills, spoke to us about it. Just to remind you, unlike the occult blood test that picks up blood from other sources, the FIT test only detects human blood in the lower intestinal tracts, and it is available at the University Health Center for a nominal cost of $5,000. You can come, ask for me, Sister Banbury. I will go through the pre-screening to see whether you qualify to do this test. And if not, and if there's any issues, I will recommend that you see your doctors and for them to further recommend you to go on to whether you need to do a colonoscopy. It is important to note that if you have had a diagnostic test before, in that you've had to do a colonoscopy before, the FIT test is not for you. The FIT test is the screening, the pre-screening before. So you, like Dr. Mills has told you, if you have no symptoms, no blood in the stool, no abdominal pain, persistent abdominal pain, no history of polyp, no history of rectal or colon cancer, the FIT test is for you. And if you do your FIT test, one test every year for 3 years, it is equivalent to one colonoscopy test. And I will not take away from Dr. Mills, it is cheaper than a colonoscopy test. So I strongly recommend that you do come and visit so that we can go through and see whether you do fit this criteria, and we're there. We have it available for you at the University Health Center. We're bringing in good things just so that we can help you look after yourself. Early detection is the key to surviving any illness, and that is why we are here, and that's why we are bringing it to you so that we can bring your awareness and have you come to us for us to best serve you the best way that we can and look after you and help you look after yourself, because a healthy nation begins where? With one person, your health, all right? And you cannot do it without us helping you, all right? And without further ado, I would like to welcome our clinical director for the health center, Dr. Tino Hilton-Kong.
Hi, good afternoon. She's welcoming me, and I'm going to say the vote of thanks. You know, that's just great. So I am going to read my vote of thanks. So I am, as she said, clinical director, and I want to start by thanking you who are physically here, despite the rain, which I'm thankful for, and those who are virtually here and there, and that you have been able to take up this excellent opportunity to increase your knowledge about your own wellness, as Sister Keisha says, and likely of those who mean a lot to you in your life. Thank you for your attentive participation. On behalf of the Office of Campus Registrar, specifically the Occupational Safety and Health Unit of the Human Resources Management Division, I'm not saying the HRMD, I just said it, and the University Health Center, I would like to thank our honored guest speaker, Dr. Mike Mills, who served a belly full of knowledge about that not so uncommon condition, cancer of the colon. And he also served as it relates to how to prevent it. He was ably supported and surprised by Patrick Williams from Indus Life Sciences, who provided some garnishes, or should I say appetizer. Maybe I should say appetizer for this. I would like to thank, I'm going to call them our M&Ms. I don't normally like to encourage sweets, but our MC, she had to leave, always busy, Nalda Thompson, our marketing and communications office, who ensured you got the messages to be here, our MITS team, who is ensuring that we can hear this, even at the health center while you're waiting patiently, and others, and also our estate management department, so that you're sitting in a comfortable setting. Colleagues, I cannot leave without saying that I want to thank our Kit and Kat without the T's. And they have not had a Kit Kat break, nor did they allow some of us who working behind the scenes to get a Kit Kat break. They worked tirelessly to organize the symposium, and these are Sister Keisha Banbury and Cadian Morris, Thanks again to all of you, and let us take some time to digest this knowledge. It's a lot, so think about it, digest it, and make ourselves and others well by passing on the knowledge, as Dr. Mills himself actually encouraged us to do, and Sister Keisha. And then, this is actually, according to Google, clapping aids digestion. So, as Miss Lou said, clap them. Thank you.
So thank you again, everyone, for coming. And this is the end of our presentation for the day. So we'll see you next week at our University Health and Wellness Fair and Blood Drive. It is called the Frank Worrell Blood Drive.
In other words, one blood saves one life. If you can't give blood, get somebody to come and give it on your behalf. You never can tell. It might very well be saving your life. Next week, Tuesday, we start at 8 o'clock till 4, Assembly Hall, and we will double it with our health.